All right, Lina, thanks for making it on, or I should say, Dr. Lina Miyakawa.
Thanks for having me, Brian.
How are you doing?
I'm good. I'm good. Keeping spirits up for sure.
Well, yeah, you have some challenging times, and we actually had to reschedule this because you lost a patient. So that's pretty intense. Maybe just start with what you do and who you are.
Sure. My name is Lina Miyakawa. I'm a pulmonary critical care medicine physician. I work in New York, New York. Mostly working as an intensivist right now in a medical ICU, dealing with COVID patients.
Wow, yeah, and you went to NYU undergrad, and then you went back home. So we grew up together in Hawaii.
Yeah, that's right, Brian. We went to high school together, so we grew up together. We've known each other for a really long time. I went to NYU for undergrad. I went to back home to University of Hawaii, John A. Burns School of Medicine for medical school. Did most of my training out in California at a place called Santa Clara Valley Medical Center. Um, Also worked at Stanford as the county hospital for Stanford Medical Center. And then I did my fellowship out in New York at Mount Sinai Beth Israel, which is where I work now.
That's great. And then what did you do as a pulmonologist? What does that mean?
Sure. So usually before all this happened, I would do inpatient and outpatient work. So I would work in the clinics, but mostly as an inpatient, I'd be dealing with patients that had asthma, COPD, sometimes with people that had more advanced lung diseases. And then sometimes I would work in the ICU also. We do both.
Hmm.
And in the ICU, we work with medical patients and also with surgical patients.
And then when did you move back to New York, and you're on the front lines. I just want to make sure people know you're out there dealing with patients in the heart of all this. So how did this all happen?
Sure. So after my 3 years of internal medicine training out in California, I moved back to New York for another 3 years of pulmonary critical care medicine training. And that was in 2015, is that right? 2015 to 2018. So I
Hmm.
finished my training in 2018 and I stayed on in the same hospital to become an attending. Um, Now, we all know that this started a couple weeks ago, and we got our first patient about now 2 weeks ago, maybe 2.5 weeks ago. And I was serendipitously in the ICU as the ICU attending when we got our first patient. So we've gotten a slew of patients since then, and I've lost a few already. So.
That's really sad. So how does it work? How many hours do you work? And just tell us more about what you've seen.
Sure. So normally in ICU, we work 7 days on straight, so Monday through Sunday, and we are on anytime from 7 or 8 a.m. all the way till whenever it ends. So we're not
Hmm.
quite like emergency medicine doctors where we actually have shift work. Even with them, sometimes with catastrophes like this, they stay on longer. But for us, we're trying before all of this there wasn't quite shifts. You were supposed to be done by around 7 p.m., so 12-hour shifts really, but if there was someone sick you'd stay longer. Now with this, it's gotten the lines are even more blurred. So right now we have moved from the 7-day model to a 3 to 4 day model, just because of the intensity of the work we're doing now. We're not able to last for the 7 full days. So we've moved to a 3 days on or 3 or 4 days on and then 3 or 4 days quote unquote off, which means, we stay at home and work on protocols from home, take calls from home, do things like podcasts like this. Talk to you,
Hmm.
Brian.
Well, that's great. Yeah, I think it's really interesting to hear from someone because I've heard all different stories, sides of this, and from immunologist people or epidemiological disease people, but I've never heard from someone in the front lines. So well, it's crazy. I've seen videos of people on the ground in New York hospitals on the side, against the wall because they've run out of beds. What hospital do you work at, and what is the situation like?
So I work at Mount Sinai Beth Israel. It's part of the Mount Sinai system. So in Manhattan, there's 4 hospitals, and we also have hospitals in Queens and Brooklyn, out in Long Island. Um, So we're all working as a system. We have system calls to kind of look at the numbers within all the different hospitals that we have. I specifically am only at Beth Israel. Our fellows do rotate amongst 3 of the other hospitals. So as a fellow, I got to see Mount Sinai West and Mount Sinai Morningside, and Mount Sinai Uptown, which is on the Upper East Side, so the 4 hospitals. Our hospital has gotten a lot of patients, but I do hear from my colleagues out in Long Island and Brooklyn. They've gotten a surge much earlier than we had, and so they are, for lack of better terms, bursting at the seams right now.
That's too bad. And
yeah.
So is it on the upswell right now for you? Is it like a constant? Is it waxing or waning? Like what are you seeing?
So it's only gotten worse since we have gotten our first few patients. We've now opened 2 more ICUs, and we're having to open more ICUs about every 48 hours. So we opened another new COVID positive ICU this week on Tuesday. And then we're thinking about opening another one by tomorrow, the day after. So we've filled out that one unit pretty quickly within 48 hours. So it's growing at an exponential rate right now.
And how are you converting these? Are these people who are getting non-elective? They would have been getting non-elective surgeries and then be converting to this?
So what's kind of fortunate about our hospital is our hospital was transitioning.
Sorry, I meant elective surgeries too.
Oh, elective surgeries. Yeah, I got you. Yeah. So our hospital was transitioning to a smaller hospital. Our hospital has over 800 beds. And so it was essentially closing and transitioning to a smaller hospital. So we actually have the bed space to open back up. So it's been very fortunate that prior ICUs that have been already closed down that have been able to be reopened for usage. Now, personnel is another issue. Obviously, we need nurses, we need physician extenders, we need physicians to be able to staff all these different units, and so that's been something we've been working on. The elective surgeries, of course, have been canceled. Governor Cuomo has mandated that very early on, and that had been in effect since last week. That doesn't mean that there aren't surgeries happening, because if there's any emergent surgeries, they do still happen. That means any traumatic injuries or any malignancies that need to be taken care of that are time sensitive, that's still happening.
So what does the life cycle look like of a patient coming in and out, and how long, and what is like the procedure? I just don't know anything about this.
Sure. So I think, again, I'm no expert in this. I am just working on the front lines, and this is all anecdotal. I don't think anyone has the answer to what it's going to look like life cycle wise in the US. We do have reports from China and from Italy and from the UK that's been able to kind of see it all the way through. But what we're seeing so far is some of these patients die pretty quickly. When they come in, they sometimes are okay and they can leave. But if they're very sick, they can decompensate, deteriorate within 12 to 24 hours. That means going from just room air, meaning breathing normal air that we breathe, all the way to being on oxygen, some nasal cannula just goes in your nose, and then all the way to being on a ventilator, so a life support machine. That's within 12 hours. It's really quick. It's not something that we normally see even with the flu or with a bacterial pneumonia. So that happens, and then if they get sick and they come to our ICU, a lot of patients have been kind of stuck there on a ventilator, and we've been doing a lot of different things to try to keep them alive and keep them well. But we're looking at weeks and weeks, I think. A lot of these patients have to be paralyzed, meaning their oxygenation is so low that we're trying different measures to try to keep their oxygen high enough to keep them alive. One of them is paralyzing them, using paralytics to make sure that they're very concordant or they're cooperative with the ventilator. And then we can prone them, so putting them face down, essentially, flipping them over. We do things like that. And so some of these patients have been on the ventilator now for 1 or 2 weeks. And I think we're looking at a marathon here. We're looking at weeks not and maybe to months of all these patients. And the tough thing with all of this is, we'll start running out of room, we'll start running out of ventilators, and more patients will start piling up in all these ICUs that we've made.
Have you been, so you haven't had to improvise ventilators or do anything that because you're not to capacity yet?
No, we haven't. I know a lot of YouTube videos out there about kind of jerry-rigging, ventilators to make sure that we can, if we run out of ventilators, we can put, 2-4 patients on one ventilator. I have not had to do that yet. I know there's talk about that out in Long Island and Brooklyn, and out in Queens. Those are the guys that got hit first because they are running out of ventilators. We are looking at that. The issue with, I don't want to get too much into the science, but the issue with that is there's a thing called volume trauma, or essentially too much volume in the lungs from the ventilators can cause trauma to each of the lung units that exist inside both of your lungs. And so you want to make sure you match your patients correctly if you're going to be doing that. So, a lot of this stuff has been done in a simulation world and not necessarily on patients. And, we're coming into a lot of these medications, a lot of these things that we're doing to these patients in an experimental sense. So, we have to do everything we can to try to save these patients, but there's a lot of things to be considered. So it's difficult.
And then, it sounds like it. So these patients that turn quickly, are these the elderly? And because, most people have heard it's, maybe you're okay because you're a young, healthy person. And is that the case?
So if you look at the statistics, over, 75, 70, definitely over 80, about 1 in 5 is your mortality rate. So 20% is your mortality rate. Now, if you're younger, the odds are better. Odds are more in your favor. However, I have seen some of our patients that are much younger, in their 30s, become very, very ill. And some of them do not have any comorbidities, meaning that they have no other medical issues. So we don't really know who's going to get affected, who's going to be very, very ill. We do have a couple patients out in other institutions that are on things called ECMO, which is essentially a machine outside of your body, heart and lungs, essentially working as an outside unit to kind of supply, oxygen and blood to the rest of your body. Those are 30-year-olds. There's postpartum patients that are in their 20s that are on a ventilator. So we know that, younger patients are not spared from this disease.
Do you have any idea? So they don't have any comorbidities. Have you asked them, do they smoke? Do they do anything else? Is there anything that we can guess about this?
Yeah, the recommendation is currently if you do smoke or you do vape, of course, that does put your lungs at risk. And so we are recommending that you stop doing that. But we don't know exactly what the risk factors are for getting this disease. So anything that could put you at risk, that's what we're recommending. And, a lot of this information is on the CDC and WHO websites. And I think that's what we are going off of. That's the most up-to-date information that we have right now.
Do you have any other anecdotal stories of people that you could just share with just what you've seen with older people, younger people, anything like that?
Sure. Before this, I've never gotten consent for an experimental drug. So this was my first time doing that as an attending, getting consent to put somebody on an experimental drug. Of course, the patient was already on a ventilator, so I'm getting consent from a family. So one of my patients that wasn't doing so well, that went into renal failure, they weren't able to get this experimental drug, but the next person that came in, I wanted to try to put them on it. And so I called the family and I asked them, I read through the paper because they have to sign a consent form. Essentially, this paper really said nothing, right? We don't know how this drug is going to act on your patient, on your mom, and on your loved one, on your wife. But it could save your wife's life, or it could kill her. We don't know, but we have to give it a shot. And essentially, I told them, "Thank you for putting your faith in me." And they said, "Whatever you can do, please, save my mom, save my wife." And we've done it. And have we seen any good effects from that? I think it's too early to tell right now. We don't know.
Hmm.
but I haven't seen any great effects from any of the drugs we're really using so far. It's kind of a crapshoot, honestly, right now. So we're trying a lot of different things.
I read an article about a New York doctor, actually another pulmonologist, using vitamin C and 3 to 4 times per day. So it's like way over the normal recommended dose. And he, anecdotally said good results. Do you know anything about that?
Sure. So vitamin C has been looked at in septic shock. So that's sepsis is essentially a overwhelming response from an infection in your body. And so there's been trials of vitamin C in sepsis. And so it's a lot of the drugs that we're using, we're extrapolating data from different things that we've done in the past that are similar to what we're seeing. So our institution is using vitamin C also, but also, again, anecdotal. We don't know if this is going to be great or not. There's a lot of other stuff that, have been in the news and published on things like prednisone, Plaquenil, remdesivir, tocilizumab, a lot of azithromycin. A lot of these are drugs that, are being thrown around. And I think, again, all anecdotal, but we're doing everything we can to kind of see if any of them will help these patients.
Yeah, I'm just looking at these. There's some, going around Twitter. It was, azithromycin, hydroxychloroquine, and zinc
Yeah, that's the
sulfate.
Plaquenil.
Okay,
Yeah.
and then zinc sulfate. Do you know anything about that?
So
Is
the
that
zinc
just name?
sulfate goes hand in hand with the vitamin C, actually. So same thing. Yeah, not quite the same thing, obviously, but in the similar trials that were looked at. Yeah.
And then what about vitamin D? So I'm a big proponent of getting natural vitamin D from the sun, and we were lucky to grow up in Hawaii, and I just been getting a lot into tracking even flu seasons, and the season is really when vitamin D is at the lowest. So have you looked into this type of thing at all?
I personally haven't at all, but you're right. I mean, we're from Hawaii. I love the sun. I was just, outside on my balcony today, just trying to get some sun because I'm just constantly inside. We're not giving vitamin D at all to these patients, but maybe it's something that we need to look at. Who knows?
Well,
I'm not
maybe for
sure.
prevention, really.
Yeah,
Yeah, I mean, I know we can't make recommendations, this is not medical advice or anything, but I mean, just getting
totally.
sun and just getting also, uh, just, I don't know. Yeah, I go outside, I lay in the grass. I got kicked off the beach the other day. I tried to go, to the beach very distant from everyone else, and the cops came immediately, which is a good thing, I guess.
Wow.
But
No
yeah,
kidding.
but I found a grass strip where I can get some sun. But I guess
Yeah.
I'll just say it then. Go get some vitamin D, and then maybe you could supplement if not everyone is as lucky as living in LA or Hawaii. But
Totally. I think right now, all the healthcare workers were telling people to stay home, but we also have to be able to protect your emotional and psychological health too, because if we're telling people to stay at home and they're not happy at home, and a lot of that comes from the sun and being outside, right? A lot of people are happy being outside and being in the sun, and we're telling people you can't do that. And so I think, whatever we can to stay healthy and mentally healthy, I think is really important right now.
yeah, just do it in a responsible way. You are
That's
allowed
right.
to go outside and do exercise. Just don't congregate. So
Exactly.
yeah, so you're really big
Exactly.
on this sort of shelter in place, and you really believe in that. I'm guessing you're spreading this message.
Yeah, definitely. I think um, I'm not sure if you've seen some of these kind of digitally made graphics, but if you put some people in quarantine, it doesn't work just as well as if you do the shelter in place. So if you have maybe 25% of the population shelter in place, stay in one place and stop spreading things, even they may be asymptomatic carriers, we don't know. It really stops a spread and it really flattens the curve. So I'm definitely a component of stay at home, stay away from people, 6 feet, sneeze in your arms, wash your hands, that type of thing.
Yeah, yeah, definitely. Yeah, I mean, a lot of people didn't take it seriously in the beginning, but now everyone knows. I mean, it sounds like if everyone just stays at home in the entire world, it couldn't spread. I know that's not possible because people have to get food and stuff like that. But what have you heard about this? The Imperial College of London talking about their projections that it's going to be 18 months. We need to be locked down for 3 months. Maybe we can get, off for a little bit for 1 month and then back on for 2 months. Do you think that we need to wait until this vaccine in the supposed 18 months, or have you got any information? I know you're not the epidemiology expert and immunologist person, but have you gotten any of this info from your hospital?
So you're right. I don't know the answer to that, but I do know that we as physicians are preparing for this at least into end of May. At least. And that's just on the front lines of making sure that we have the staff and the materials ready to kind of prepare for that out until then. And just personally speaking, I don't think it's going to be over then, just looking at how these patients are doing now and how long it's taking them to recover. I think we're looking at weeks and months out. I don't know about 18 months. That seems really long, just even to me. But if we don't kind of put an end to it now, and I do still see on the news people being out and about and, interacting. So if we're going to be doing that, I don't know if we're going to be able to, put an end to it in weeks.
Yeah. And so what about the testing? I hear there's just a lack of testing, or what's the best protocol? Because some people, they're getting tested too late, or they're told to go home and come back. Do you know what's going on there?
So again, this stuff changes a lot. This has been changing, day by day. So CDC has the most up to date about that. Our employees, it's the recommendations and guidelines of when to get tested, things like that are also changing day by day. But for everybody else in the world, we recommend that if you're feeling ill to just stay at home and really kind of self-quarantine yourself. If you have to live with somebody else, then, use a different bathroom. Try not to share, the similar space. I know we can't all live in our garages, away from your loved ones, but to try to limit the spread within the family and the clusters. We are testing a lot of people now. I was at I was one of the providers very, very early on, where in New York, we were only sending the test to DOH, so Department of Health, and then also another private lab company called LabCorp. And the tests were taking 5 to 6 days to come back. Just to tell a short story, one of the first patients that came in, I didn't know she was positive or negative for 5 or 6 days. I had a very high suspicion. Finally, it came back with 6 days later, and by then it was too late for her to get any experimental drug, and she died. So her kidneys failed, her heart shut down, her lungs shut down, and so it was very unfortunate back then. And so there was this big push not to test a lot of people up front because DOH and LabCorp were being overloaded essentially, and that's why it was taking 5 to 6 days to come back. Now, most of the institutions in New York, so Columbia, Cornell, NYU, Mount Sinai, Northwell, we all have our own testing being done in our labs, and so the return time is very quick. It's hours. So that's really helping a lot, actually, to make decisions on how to treat these patients.
That makes sense. Would you do things differently? Yeah, other than give them experimental drugs, I mean, would you just try to do interventions the same way before you know if they have it or not?
So unfortunately, a lot of these drugs are being regulated by not just the FDA, but by the government now. And so it's up to them about releasing the drug, and they have to be positive before they can get the drug. Because if you can imagine, even if it's a high clinical suspicion by me, I could be wrong. I've been very humbled by this disease. A lot of my clinical acumen has been wrong sometimes, a lot of times, I should say.
It's hard, yeah.
So it's been very difficult. And so, you don't want to trust just my clinical suspicion that somebody has a disease, because the drug itself could hurt you. So you want to really be selective on who gets the drug. And that's why. But even, like I said earlier, the drug, it's not a cure, right? Again, it's still experimental. So I think, just testing wise, I think the point is it's great that we're able to get it back so much quicker now. So we've made some changes there.
Yeah. So how have you been protecting yourself? What does it look like when you go in there? I can't even picture this.
People have been asking me for photos, and I just haven't had the chance to kind of like get a whole photo of me in the
Yeah.
garb yet. I have one from the back where I'm intubating somebody, but I know everyone's seen from China, from Italy, this whole thing that looks like a spacesuit, like a bunny suit is what they're called. We don't have that. What CDC and WHO recommends for people that are doing high risk procedures, so that would be me in the emergency room, we are recommended to be in airborne precautions. What that means is the N95 mask that looks like a green mask that's for airborne precautions. So tuberculosis or measles, that's what you'd use. So we have that mask on. Then on top of that, we have a regular surgical mask to cover the N95 mask because we're now reusing the N95 masks. So once the N95 mask is covered from the droplets that come up, we can reuse the inside mask. So then that's surgical mask. Then we have goggles to wear that are also reusable, so I can wipe that down with Clorox after I go in the room. I have a bouffant cap that goes on top, looks like a shower cap. And then I have a yellow gown. Essentially, it doesn't let any droplets go through, and then gloves. I double glove for intubations. Just for examining patients, I only have single gloves. And then just scrubs inside of all of that. That's what it looks like.
Wow, that's intense. Well, we got to share a picture of that
Yeah.
at some point. So what
Totally.
kind of specific interventions have you done? And what are these procedures?
Sure. So I think the highest risk procedure I've done so far is a bronchoscopy, which is not recommended to be done unless it's absolutely necessary. So I've only done one. I've been avoiding doing all of those. That is essentially, everyone's heard of a colonoscopy. So it's a long camera that goes inside your mouth and down into your airways to take a look. You can collect samples, you can do biopsies, you can do washes. But if you can imagine, since you're going into the airway, there's a lot of aerosolization of droplets, and so that's a pretty high risk procedure. The second most high risk procedure I would say is the intubation, which I've done a lot of now at this point. So that is when you put somebody to sleep, put a tube down their throat, hook them up to a life support machine, a ventilator. That we paralyze patients for that so that there's less risk of aerosolization. But of course, it's not perfect. I know that there's been a lot of things on Twitter and Facebook about these people building these plastic boxes that go over the head of the patients, and then there's holes on the outside that you can put your hand through to do the intubation, so that there's no aerosolization coming out of the box. They're using these plexiglasses and super glue, which is awesome. There's like an outpouring of support from people staying at home for healthcare workers. So I haven't used one of those yet, but maybe that's coming down the line.
And then, do you feel safe? Are you worried about this, or with all your gear and everything, you feel good?
So, I think there's a lot of anxiety right now and a lot of fear, even in healthcare workers. It's really palpable every single day when I walk through the hallways. I think, I really believe in leading by example, and I feel very confident that if I wear the correct personal protective equipment, the correct PPE, and I protect myself and I take it, I don it, it's called donning and doffing. If I doff correctly, I should be well protected. I think we have to kind of show that to the rest of the staff, to how to do things, and not be afraid to treat patients the same way that we're treating them before all of this. So I think that's really important, and I do feel safe when I am wearing the right PPE, and I still have some, so that's good. We haven't run out yet at our institution.
That's great. What else is just the atmosphere like? Is it kind of panicked? Is it kind of just everyone's calm? And the patients, and then the staff.
So let's start with the staff. I'm very lucky to be working with an amazing group of physicians. They trained me, of course. I'm the youngest in my group, and I have full trust in them. And I have essentially been deputized as my ICU director to be a part of a lot of these higher decision-making trees, which I'm very happy to be a part of. And so our group has been very steadfast and very strong together, and everyone is very calm. And I think with that, we are kind of forming teams with our hospitalist team. So those are the guys that work on the medicine floors, not the ICUs. And then we have been working with the residents and the fellows, so the trainees. And everyone has been kind of getting the hang of everything. I think at the very beginning, there was some panic, there was some anxiety, there was some fear. And I think being very open with them about everything that we're doing to prepare for everything that we can to prepare, I think there has been more of a calm that has set in the last week or so, which is great. The nurses and the respiratory therapists are great. If there is any emergency on the floor, everyone knows that we have to protect ourselves before going in the room. And that has become a very routine thing amongst all of us. So that's very important. So that's the staff and the patients. The patients, I've had a couple that are very depressed about all of this, very anxious about all of this. So it's a lot of reassurance. On the outpatient side, I take calls we are doing telehealth to try to keep patients at home that don't need to come in. So we are talking to them on the phone, talking to them over FaceTime, things like this, to just reassure them. But there's a lot of anxiety around that. In patients that have COVID, of course, they're very anxious, very tearful. And we can only try to reassure them and, try to be at their bedside to calm them down.
Yeah. Do you have any other messages? I'm going to let you go here. I know you're, tired and working hard at all this, but any other stories or, closing messages for people out there?
Sure. Brian, I really want to thank you for trying to get the word out and letting me come on this to talk to you about all of my experiences. Again, I'm on the front lines, but I don't know everything about this, and no one knows everything about this. But the only thing I really do know is the only way to stop this is from the outside. I can't stop this. None of the healthcare workers can stop this. We're only treating patients from the inside. If we don't stop this on the outside, we are going to be overrun. New York City is already overrun. We're asking for critical care physicians to come in from other states to staff ICUs. We have too many people on ventilators. We're running out of ventilators. If this goes to anywhere like our home Hawaii, we will not be prepared. There is no way Hawaii can deal with this. And we're attached to a huge landmass. Hawaii is not. So I think it's really important for people to be very respectful of these. They're not suggestions. I think they should be mandates for staying home. Staying away from people 6 feet. Don't congregate. Putting off things like weddings, going to church, things like that. I think that's really important. So that would be my main message here.
I love it. And and I guess I'll just say thank you as well. And everyone listening, it's scary times, but do what you can to stay healthy. And I'm using this opportunity to eat even better, to work out even more, home workouts, just, there's a lot of things you can do and think positively and be optimistic about this. And I'm sure, we'll all pull through. We're pretty smart as a civilization.
It's true. It's true. Please stay healthy mentally, physically, take your vitamins at home, eat healthy. I think that's super, super important, Brian. Yeah.
All right. Well, thank you so much. And I hope everything goes well with you and everyone, you stay safe.
Yeah. Stay safe, Brian. Thanks so much.